Dealing here, I want to know how many people in the room think that our Canadian healthcare system should provide all known health benefits to anyone who requires them without delay, no matter how small the benefit and how great the cost. By a show of hands. Actually, some of you might think this is a strange question, but there are people who firmly believe that. Okay, we'll see what you think after I've presented. This is a very interesting group. I'm very happy to have the opportunity to speak to it. Dennis Barkas and I were both at a class at Ryerson University where I was asked to make a presentation on this topic, so this is a sort of modified version. We don't have PowerPoint presentations, so that renders me functionally dumb. But I'll do my best. We are working under the Canada Health Act of 1966 and then modified in 1983. And just to remind you, I'll tell you what are the 4 or 5 major tenets of the Canada Health Act. 1, funding is tax funding national public funding. 2, it's universal. That means it includes everybody who's eligible, namely citizens and landed immigrants and many others. 3, it should be reasonably accessible. 4, it's portable across the country. You can fall sick if you're in BC, and the bills for your services go back to Ontario, and they pay them. Now, here's the rub. The 5th one is it has to be comprehensive. And the definition of comprehensive is as follows, quote, all medically necessary services provided by doctors and hospitals. So right away, of course, we only have about 70% then, because 30% of these services are other than doctors and hospitals, such as home care, all kinds of other therapies, drugs, etc. So, just to digress for a moment, humans evolved about 300,000 years ago. There's some debate about that. And for the first 249,500 of these years, the average life expectancy was in the 20s. It would be rare to reach more than 30 years old. The neonatal and child mortality was around 50%. And death in childbirth for the mother was in the region of 10 to 15%. Now we have changed that today into a life expectancy at birth of approximately 80 years. Neonatal and child mortality right now is 6 per 1,000 in Canada, which is getting almost to the absolute biological low limit because of genetic deformities. And death in childbirth is virtually unknown for mothers now. There is about 1 per 8,000 births. So what's the problem then about comprehensiveness in the healthcare system? Well, here's the problem. It was designed in 1962, legislated in 1963, when there were only 3 antibiotics on the market. There were no hip replacements, there were no knee replacements, there was no cataract surgery, there was no transplant surgery, there's no open heart surgery, very limited neurosurgery, no microsurgery, no very limited vascular surgery, no artificial insemination, no in vitro fertilization for infertility, no, quote, gender confirming surgery for the LGBT folks. And the high life expectancy, of course, just simply means you've got more people living for a longer length of time, as was properly referred to. We had no screening procedures for diseases that may or may not exist, and we had none of the advanced cancer drugs that we have at the moment. So when it comes to comprehensiveness, we're getting to the point of impossibility. And this, I hate to have to say, because my whole life I've been a very staunch defender of the single-payer system and the Canadian model as being as good as any and better than most. So what tools do we need to deal with the complex of the question then? Now I don't want to get too technical about this, and I'll skip over them fairly fast. We need to start talking about cost effectiveness. That is, what is the cost per unit of effect? And we need to think twice about a drug that costs $100,000 per person and gives you an extra 2 months of life, just for example. There's also the question of the number needed to treat. Now that's a term used in clinical epidemiology. What it means is, if you're trying to treat a condition, so you take 100 people with the condition and you give them a drug, and it works fairly well for, let's say, 10 of them, then your number needed to treat is 10. In other words, you're giving the drug to 100 people, but only 10 are benefiting. And then lastly, and perhaps most of all, important as all, is, again, it's a ClinEpi concept called the opportunity cost. Do you have a sense of what I mean by that? It means anything you spend, what could you have spent it on much more sensibly in terms of the amount of benefit, which gets back to cost effectiveness again. So a classic example is Herceptin, for example, for disseminated breast cancer. Huge debate about it. Originally, no sensible health authority wanted to fund it under tax funding, but day after day, the government can only stand so many newspapers in which the front page is how the government is killing women and refusing to deny them the benefit, which only works in about half, or less than half actually, of women in the first place. And what is the benefit? It is approximately 3 months average increased life at a cost of $70,000 per patient. So this is one of the classic examples, which is very difficult. And I know that this will not refer to the crowd here tonight, but the great unwashed public out there has tremendous difficulty discussing any of this, as do politicians, because they're terrified of the election possibilities. So I'm going to skip watching the details of Herceptin cost analysis, but it's really pretty poor. So we're getting near what's called the asymptote of the curve. That is, we can spend hundreds of thousands more dollars and just get a very, very slight increase in measurable health. Whereas if you're talking about smallpox vaccination, for example, then you're talking about saving everybody's life who gets it for a cost of $3 or whatever it was, and now we don't even need to do it at all. And it gets worse because we're now in the era. Do any of you watch television once in a while? Silly question. There's hardly another month goes by that we don't have to deal with yet another drug. Most of them end in MAB. Avucazimab, Rituximab, Imab. These are the new so-called immune modulators, which are in the range usually of $50,000 to $100,000 per person. And the drug firms say they work. So if you question what does they work mean, then again we're back to largely unproven long-term benefits and short-term benefits, which may help a few people a few at a time. And even worse, there are the super expensive drugs, and we're talking about genetic enzyme deficiencies now, in which the baby would mercifully die fairly rapidly, but the genetic deficiency is identified, and treatments, for example, for cystic fibrosis, $300,000 per year for the new medication per patient. there's a particular form of nocturnal hemoglobinuria, never mind, it's a fatal disease, and it's worth $700,000 per year per patient. And so the debate goes on. So finally, what are the options for dealing with this issue or for decision making in this area? I've got 4 listed here. 1, let's continue at present, which is highly likely to be the option chosen because everyone's terrified, I won't use the word, of doing anything about it. And of course what that will do is progressively rob our society of a large variety of goods, other goods that we will not have in terms of other services. You mentioned Ontario's 40%. The average provincial budget expenditure now on health is about 45 to 46%. Okay, that's number 1. Number 2, more taxes. Some people are in favor of you just pay what it needs. I mean, people need these drugs, so let's pay for them. We'll see in the discussion how formed you are of that one. Number 3, reduce coverage. Now, to some extent that's being done, and it does make sense to reduce coverage based on firm evidence of benefit, because we're doing all kinds of things right now that are of very questionable benefit. So if we can find the hard evidence and reduce them, then that makes sense. As was mentioned in the introduction, I chair the Ontario Health Services Advisory Committee. That's the body that makes recommendations to the ministry, and I'm still on the committee. And it's a very hard job, but we have to make recommendations based on cost effectiveness and thoughts about opportunity cost of, where could the money be better spent. And it's all very difficult, not only difficult, but very distasteful to many people to discuss this kind of thing. So that's number 3. Number 4 is repeal the Canada Health Act completely and design a new system. Now that has been advocated for many years now, and the huge majority of what I'll call thinking healthcare administrators, of which there are a few, feel that this is a necessity because the concept of how it was devised in 1962 simply does not match the reality of the services available and the disease complex and the population of today. So there's just a few suggestions that you might like to discuss, or any other questions I'll be happy to answer.